Trauma team response. We know critical care is best delivered in a pre-organized team framework. Ideally, that process involves identification of the type of team needed and the components to make the team response effective. When the team should be mobilized, what type of team members are required, the location and configuration of the response, responsibilities and tasks of the team members, organization of required equipment, supplies, and medications used during the response, documentation forms, orders, checklists, policies, procedures, and references, and methods for notifying team members to respond. Effective teams possess 5 characteristics of success. Commitment, meaning practice, practice, practice. Common goals, everyone shares the same goals and has the same priority, the patient. Competence, this means skill days, knowing the equipment, running drills. Consistency, they have guidelines, practice, review, and debrief. And communication, effective, clear, closed loop, and respectful. Consider the differences that make developing a trauma team different than other types of team responses. There's a potential surgical focus, early identification and intervention of life-threatening injuries, prioritized coordination of care, early recognition of the need to transfer to definitive care, stabilization interventions, documentation to go, and COBRA EMTALA procedures. We have many types of teams that have been proven successful and effective for a variety of situations. Here's a list of some of them. This is a photograph from 2008 Advanced Disaster Life Support course. The goal of the trauma team is rapid assembly and immediate provision of multidisciplinary personnel and equipment, ATLS assessment and intervention, a coordinated, interdependent, and standardized approach, optimal communication, timely treatment, stabilization, and transfer if unable to provide definitive care. The trauma response consists of these specific components and the successful process of linking them together locally. We start with the trauma team with defined roles, plus trauma activation criteria that's known and accessible, plus activation and notification procedures, plus equipment, supplies, and forms already organized and easily accessible, plus practice, plus the review of timeliness and appropriateness of care. When it comes to the first component just mentioned, who do you want to have on your team? Specific members of your trauma team depend on the professional resources you have available. Here is a list of common team members. Depending on facility size and scope of the situation, consideration may also need to be given to identifying resources for coordinating the rest of the emergency department, subsequent shifts, and the rest of the hospital. Here are some potential players. Effective team leadership is based on experience and wise application of calm, collected, reasonable, well-prioritized direction. Even inexperienced staff will perform well if effectively led and directed. Teams do not perform well when leadership is fragmented, chaotic, and disorganized. And more importantly, patients do not do well if care is fragmented, chaotic, and disorganized. The team leader has to have an understanding of the roles and responsibilities of the team members, utilize effective communication, cooperate with the team, be organized, and lead the pre-arrival briefing and post-debrief. Here are some things to consider. Nurses, physicians, and EMS are educated in isolation of one another. We all learn the same ABCs of trauma care, but we learn to do so as if we're alone. Trauma patient care is delivered by a team of these individuals who know what they're doing, but may not know what the other members are doing. Situational awareness is especially important in a task-oriented structure. Models have been developed to teach teamwork, which may be very useful. Effective teamwork can be quite challenging. These tips will assist staff in becoming a more effective team. Assign roles before the patient arrives. Use closed-loop communication. Once asked to do something, team members repeats it back to clarify and ensure the correct information. Only one person should talk at one time. Delegate tasks to individuals, not to everyone. Challenge culture. Anyone on the team may validate decisions or provide input into care. Communicate the plan to the whole room and team. And practice on every emergency department patient. As you develop your trauma team response plan, remember to be realistic and use what you have not what you'd like to have. Should you develop different levels of trauma team response, or are your resources such that a single level of response will be most effective? Can you offer different levels of response? Do you have a surgeon to direct trauma care or surgical services to provide operative intervention? Are they available all of the time? Some of the time? Never? Identify who has authority and responsibility for team activation and make certain this is well documented and communicated in advance. Identify what standard actions need to be accomplished during your activations. Identify which role is going to do what and assign it in advance. How many people are going to be in the room to meet these action goals? And where do they position themselves? This busy diagram illustrates a very basic team, its members, their identified duties, and physical positions in relation to the patient. Your facilities team may look different, but this general template can serve as a guide for developing your team composition and role responsibilities. Be sure to include your facilities' available team members. Educate staff and provide the guide for all to easily refer to during a trauma team response. The next few slides will illustrate different ways to assemble team members in the room with the patient. Feel free to pause at any time to get a closer look. These diagrams are also available in the resources section of the module. This picture shows plenty of help, lots of resources, and all of the necessary equipment at their fingertips. This is a well-oiled machine. Here is the reality of the trauma team members, resources, and equipment we may actually have available. You must have a reliable means of communicating with all members of your team. A pager system, phone tree, overhead announcement, or answering service may be used to communicate trauma team activation. The communication method should be reviewed if any delays in response occur. For in-house and out-of-house staff, a clear understanding of who contacts whom and when is needed. At what point do we need more than the trauma team? What then? Define this. You have your team identified, they know their roles, and now it's just a matter of time before a patient arrives. Let's talk about the activation of the trauma team response starting at the arrival. EMS should have the hospital's trauma team activation criteria and provide report prior to the patient arrival. The trauma team should be present and ready prior to the patient arrival. For those not coming in via EMS, upon recognition that a patient arriving by private-owned vehicle has triggered any of the criteria, the trauma team activation is made. Patients arriving by privately owned vehicles are managed with the same processes as those activated by EMS. Delays in activation should be addressed through the performance improvement process. Some trauma centers have a single level of trauma activation, while others have multiple tiers, usually 2 or 3. All levels are based specifically on the hospital resources available. Using a defined multidisciplinary approach to care will limit the waste of resources caused by excessive team activation, or over-triage, while ensuring resources are available to prevent delays in care, under-triage. Activating or mobilizing the trauma team to provide immediate resuscitation to the injured trauma patient is vital to both saving lives and the efficient functioning of a trauma hospital. Policies are needed to define the hospital's trauma activation criteria and to document expectations for members of the trauma team. Policies should include when the team must be assembled, who is to respond, and how they are to be notified. Trauma team activations may be implemented in different levels based on volumes of patients and the size and resource of the facility. Larger facilities with more patient volumes and resources, levels 1, 2, or 3, tend to have 3 levels. Trauma alert or full activation of full team with immediate response of a surgeon, an OR crew, and anesthesia. They can have a trauma standby or partial activation, which means a portion of the team with secondary response of surgeon, expected time of response being longer. They also can do a trauma consult or evaluation where a general surgeon is examining the patient with a not specific time. Smaller facilities, levels 3 and 4, may utilize 2 levels of trauma team activation. There's trauma alert or full activation, which activates the full team with immediate response of a surgeon and/or anesthesia if available. They can also do trauma standby or partial activation, which activates a portion of the team. It may not require calling in staff not currently in the hospital. Level 3, 4, and 5 trauma centers may also use a single-level, all-hands-on-deck approach for trauma team activation. Be aware of the organizational pitfalls that can derail effective use of trauma team activation criteria. These include criteria that are too broad, confusing, and don't establish clear authority to activate. Criteria may not be accessible to all, buried, lost, or not posted. Criteria need to be reviewed and evaluated. Revise as needed. Please note, do not use the revised trauma score calculator for trauma team activation. This scoring system gained popularity as a field trauma triage method for assessing patient severity. It was a well-established predictor of mortality. There is a lack of primary evidence supporting its use as primary triage tool and as predictor for outcomes other than mortality. Only use the Glasgow Coma Scale. Once again, while it is essential that EMS is knowledgeable in the trauma team activation criteria and uses it to consistently notify the hospital early in the call to maximize advanced preparation for the trauma patient, EMS is not responsible for activating the hospital team. As EMS and hospital staff begin to work more closely together, establishing trust and effective communication, notification from the field that EMS is caring for an injured patient who meets activation criteria will result in appropriate and effective activations. It is important staff and providers recognize it is their decision to activate the team and assemble the resources, whether EMS tells them to or not. An important part of performance improvement is the process of reviewing all activations for appropriateness, including communication, making sure EMS and the hospital are working together and identifying opportunities for improvement. If any of the links in the process are not fully engaged or participating, it's important to find those reasons and fix them. In order to keep trauma team activation effective, both under triage and over triage need to be tracked. Not activating when we should and activating when we don't need to can both undermine the process very quickly. Under triage means not activating when a patient meets physiologic and/or anatomic criteria. Over triage is when the mechanism of injury and comorbidities are used without clinical indications of patient status to activate. Both over and under triage are expected. Under triage is less desirable than over triage. It has the potential to delay diagnosis and/or treatment of a severely injured patient and may compromise clinical outcomes and increase trauma mortality. ACS has suggested that an over triage rate of 50% may be necessary to achieve an under triage rate of 10%. Make sure you address the lack of activation when indicated. If your criteria to activate aren't working, they need to be revised. When developing trauma activation criteria, it is important to consider the impact of over and under triage on the trauma system. So what if we have criteria but are not consistently activating? Well, look at the reasons. Maybe the criteria is too complex or lengthy. Maybe there's too many over triage activations, not enough physician buy-in, not enough trust with EMS reports for accuracy. Is EMS not playing along? Not enough administrative support maybe. Evaluate all of these during performance improvement. When creating trauma team activation criteria, these questions can help. The answers to these specific questions help you put together the process that will be most effective. Question 1, who activates the team? Identify who has the authority and make sure it's well documented and communicated. Question 2, what are your resources? You cannot depend on resources you don't have, so each facility's procedures are dependent on identification and organization of its resources with design of procedures putting them to best use. Question 3, when do you activate? Early notification allows for the team to assemble prior to arrival. Question 4, why are we activating? We want to provide timely assessment, identification of life-threatening injuries, and treatment, stabilization, and transfer. As we've mentioned before, EMS needs to know what your activation criteria are so they can communicate these needs from the field. Let's discuss some pitfalls that can derail a trauma team response structure. Identification of individual members by name instead of roles, not defining team members' duties once activated. If you plan to use EMS, define how and when and include them in the practice and drills. Not keeping team contact information updated, not planning for coverage due to illness or vacations, lack of orientation for new members, and failure to debrief or not including the whole team in the debriefing. Here's a major pitfall: forgetting the patient's perspective. Effective teams don't just happen. Becoming a team takes good leadership, preparation, definition, commitment, and practice. These are concepts to consider and think about when organizing, developing, and educating your staff in the realities of becoming a team. Ask yourself these questions here. Whatever you do to be successful, do not overcomplicate your procedures. Keep it simple. Documentation is an ongoing issue for all facilities everywhere. While documentation is important, other issues demand staff attention during patient resuscitation, and scarce resources may mean documentation is incomplete. The mantra everyone hears about the importance of documentation is, if it wasn't documented, it wasn't done. While this is certainly true and there is legal risk involved as a result, it is simply not a truly compelling argument for the person providing care at the bedside. A more effective approach for patient care staff is to emphasize that complete documentation really provides them with deserved credit for good care. Without complete documentation, it is difficult, if not impossible, to evaluate the care provided or identify opportunities for improvement. What promotes effective, complete documentation for an injured trauma patient? The trauma flow sheet. Many good examples exist. You should involve clinical staff to cut and paste examples and design a comprehensive form that works for them. Implementing a form without staff support means certain failure of the form. Electronic medical records present different issues. Episodic critical care requires real-time documentation for accuracy. EMR documentation is extremely difficult to implement as it happens and often requires reconstruction of events sometime later. For that reason, the American College of Surgeons strongly recommends that trauma team activations be documented on paper trauma flow sheets and not in the EMR formats. Often, trauma patients must be transferred to higher or different levels of care. EMS and ED documentation must accompany the patient wherever they are transferred to. Trauma flow sheets that are not utilized must be too complicated, don't flow well, designed by someone who doesn't use them, and not kept where the staff can easily access them. Education for all team members, including EMS, needs to consist of many components, many listed here. This cannot be overemphasized. Strides made managing trauma patients well as a team can be replicated for any other type of time-sensitive patient. This is time well spent. Effective performance improvement for trauma team activations includes evaluation of all of these components. This photo shows a team course conducted in Circle, Montana, being instructed by Dr. Kirby Peden. When we become better at managing trauma patients, we become a better ER and a better hospital.